directed a center at Harvard, Center for Public Health and Surgery. And in the last year, he has taken over and really energized the Aga Khan University Medical College in Karachi. So thank you both for joining us. Let me start with you, Dr. Hafeez, and ask you to help us frame the issue and see if you can share your ideas on how you see public-private partnership in Pakistani context, and what are you doing on this? And then we'll ask Dr. Haider to present.
Thank you, Dr. Junaid, and I hope you can listen to my voice.
Yes, we can hear you.
Okay, thanks very much. So I had a small presentation, but I'm just wondering, maybe I can go through the slides, but just give you a brief background of a bit of things which we're doing here, give you some understanding of what Health Services Academy is, what is our role as academic institution in context of COVID, and in this context, what kind of public-private partnerships we are undertaking, and what are further potentials, and then we can get to your questions, and we'll also, I'm sure, Adil is also going to add to it. So our institution, the Health Services Academy, is a public sector degree awarding institution with primarily concerned with postgraduate public health courses, capacity building, research, and policy advice for different governments. It has been there for a long time, for about more than 2 decades, but only this year it had HEC and the Parliament's approval for being a degree awarding institution. So in the last 3 months since the COVID has come in, the Academy has been made responsible for 2 or 3 very key areas. And I would list those key areas so that we are able to then think about and take the discussion further, that how partnerships can be developed in these areas, with specifically with COVID, but in general as well. So the first thing which the Academy started was looking at the data and undertaking the projections and epidemic modeling for this pandemic in Pakistan. So we realized that this was a new area for us, and there was not a lot of expertise available in-house, both within Islamabad and in many cases outside Islamabad as well. So, but this was something which we have been doing, and we have now reasonable capacity. All the official projections, which are then given to NCOC, that is the National Command and Operation Center for COVID, are kind of generated through this team. In this specific task, we did collaboration with 2 private sector organizations within Pakistan and some institutions outside Pakistan. So this developed eventually into a good mutually beneficial relationship in which we got certain areas of expertise tapped from these organizations, which we did not have full expertise on. And in return, we would also share our expertise in the data sets which were only available through the government system with the ministry and with the government. So this is one aspect of our response as in COVID, as well as avenue for public-private partnerships. The second area which was given to the Academy was to act as a clearinghouse for national operational and technical guidelines. So we rapidly developed this capacity to develop linkages with various national and international academic institutions, expert groups, organizations, to get the existing guidelines and get the latest evidence and the expertise which was scattered all around, and develop those guidelines. For example, and then these were sent over to National Command and Control Center, which there was a mechanism to get them approved through a consultative process, which was based in HSA with the provincial governments and all stakeholders, and then send them out for implementation. For example, let me give you, we have done about more than 30 guidelines in the last couple of months. For example, national COVID management guidelines have been developed through this process with various inputs from different organizations and institutions. This is the technical side, and then guidelines like holding Senate and National Assembly sessions during the COVID period, how the trains, what would be the SOPs to provide a maximum safety for the passengers. Those were developed through this process. So we also collaborated with so many organizations during this period as well. The third is the training of health workers, specifically for COVID. For this, we have very extensive collaborations. The Academy worked as a coordination hub for different institutions and looking at various possible courses, and then working with the institutions like one of the institutions which we're working is Aga Khan University, actually. Adil would talk more about it. And we have successfully conducted a number of nationwide trainings, and the process is going on. One of the trainings which the ministry has organized is We Care program for frontline health workers, and one of its components is training on PPE of these health workers. And there's a target of 50,000 health workers all across Pakistan, and one chunk of that is being carried out by Aga Khan University, which is our partner in private sector, but we also have partners in public sector in other provinces as well. So this and some other similar initiatives as well in the training. So these are 3 or 4 areas which, as an institution, as an academic institution, we have been contributing to the COVID pandemic. And then in each of these various models, different types were used for the collaboration. So I'll stop here, and maybe then we can talk more detail if there are any questions.
Sure. Thank you so much, Dr. Hafeez. Dr. Adil?
Assalamu alaikum, and good evening to everybody from Karachi. It is a pleasure to discuss this important topic on public and private partnerships. And I am grateful to you, Junaid, for putting together this excellent venue. Every week I see the list of topics, and they're always so awesome. So thank you as the director of the COE and your colleagues, including Dr. Tala, who's of course helping put them together, and all the rest in the COE. I particularly want to welcome and thank Professor Dr. Asad Hafeez, who of course we all know as the Director General of Health of Pakistan for numerous years, and now now the Vice Chancellor of the Health Services Academy. So as one medical college leader to another, I'm grateful to be able to have this conversation with you. And it kind of, shows how we approach this public-private partnership concept. I know Dr. Hafeez was going to share a few slides, but he's done such a great job without them. I'm not sure I can do it. I can do the same. So I'm going to, if it's okay with you, use some slides. Is that all right, Dr. Hafeez?
Sure.
All right. So I will show you some slides and take it from there. Can you all see my slides now?
Yes.
And you're seeing a full screen? It's fine? Okay, great. So I want to just start with how how things are done nowadays in the more modern world. We have had several colleagues from AKU who are on various task force and are participating with the federal government in a variety of ways, including Professor Samin Siddiqui, who's the chair of our Department of Community Health Sciences. And, he was chatting with me and he was talking about how he was going to have just another meeting with the federal minister of health. And, I said, look, please ask him whatever he needs, we'll do, because we have to all do this together. And I had kind of mentioned that I've been very impressed with his social media strategy on how they're doing a great job with, getting the word out and so on. And so he kindly phoned me the next day and said, look, Adil, I know you happen to be an ICU doc. And he talked about one of our new recruits from the States, another ICU doctor, Dr. Assad, and said, look, could you maybe do some work on ICU? We need some help with strengthening, capacity strengthening, and we also need some help with training. What do you think you can do? And so I said, no problem, Dr. Mirza, I'm going to send you a proposal. And that afternoon, I sent him a proposal via WhatsApp because, he's so busy. He's like, just send it to me by WhatsApp. We sent it to him by WhatsApp, and his response was this tweet, approving the idea and so on. So I just thought it was kind of a fun way to do it. And note how he, in just in a moment through a tweet, that's how fast we can do stuff now. He said, let's do this work on the ICU, and this will complement a program for frontline workers that we've initiated, which Dr. Hafeez has mentioned briefly as well. So that's just an example of how you can actually get things done pretty fast if the time is right and if you're responsive. And so here's what I want to make the point of: if you're responsive to what our public colleagues need, of course they're very quick to do this. We then signed some memorandums of understanding between the federal government, which runs through the HSA. So the signatories are actually Dr. Assad, Hafeez, and myself, and the federal minister kind of as a overseer of all that. And then since the government of Sindh also was like, well, why can't we work more specifically in Sindh because we happen to be in Sindh, we did a MOU with the government of Sindh as well. And that's been incredibly helpful for us because it's very important to coordinate at the federal level and work with colleagues in the federal government because that gives really big scope. But the Sindh government is right here and doing stuff right on the ground, and them identifying people has been a real big boon for us. The way we approach this partnership or the partnership that we've built, at least for this year, is really around three different things. We've first built this COVID tele-ICU initiative. And this initiative is basically a teleconsult for a doctor who's taking care of patients in an ICU around Pakistan. And they can call one of our experts who are there around the clock, willing to give advice on how to manage these patients. And that is helpful because, we at AKU, of course, as many people remember, we admitted the first patient. But since then, we've managed hundreds of patients, several very critically ill, and have achieved some good outcomes. So the idea here is to help colleagues who, might have not seen so many patients or are in a difficult circumstance and need another person to talk to, especially around the type of ventilator management and so on. The next thing has been educational courses. And we've done a variety of educational courses. And I'll get into a little bit more detail on those. And then the final thing was an assessment of ICUs to see how the ICUs are actually working across the nation and what is our true capacity. Now, we had planned to do these things, and in the meantime, we have the tele-ICU. They thought that this is a lot of potential. It was a peer-to-peer thing. It was a newer approach. And we're lucky that they have decided to support that. along with supporting some of the educational courses that we're putting together. The courses that we have done up till now have been several, but in particular these. One was a seminar about COVID management, and this was for all types of doctors. And we had more than 5,000 people registered. The Sindh government had sent it out in a blast asking people to register. We made it completely free, and we offered continuing professional education credits from the American group, the ACCME. And so that also helped to increase. So there was something that people get for free, but it was also an accredited thing, so people really responded. We then did, amongst that group, we then did another group specifically for critical care. And that had a pretty good response as well. About 2,000 people registered, and we're hoping to do more with the group that Dr. Assad Hafeez's colleagues have trained and identify from within these groups people who would be using that teleconsult. And knowing that it's not just about the doctors or the critical care specialists, but we also did courses for our paramedical colleagues. And it's amazing, more than 1,000 people showed up for those courses, all done online, and all the content for anybody who would like to see it. You can visit the medical college Facebook page. They're all linked there. We have a YouTube channel, so it's all linked all the time. We also, created some content. Hold on just one second. I'm gonna have to stop sharing and come back for just a second here. We also, have been doing considerable work to try to get people to phone our teleconsult service. So what happens is, well, here's how it works. So, and that's how it works. We have medical students, running the hotline. They sit there, and then when people phone in, they actually create a chart for the patient and get the baseline information and get the information about the doctor and the kind of level and the questions that they have. And then they'll get the expert consultant. Most of them are double board certified or board certified in pulmonary critical care to then talk to the person, the doctor. Calling. And then finally, we are grateful that Dr. Assad Hafeez and colleagues at the Health Services Academy chose AKU as their partner in Sindh with the goal to train 50,000 healthcare workers in the proper use of PPE. And I got to tell you, for all that we thought we were doing great at AKU, we think we know how to do education and so on. It turns out that this really well pre-packaged thing made by the HSA for everybody is, way better than what we would have made on our own. And we ended up giving this not only to people across Sindh, but we started actually with AKU personnel. And we have, in the past couple of weeks, as soon as they get it to us, trained thousands of our own personnel. Anybody you can imagine, from our, people, our housekeeping staff, to our nurses, to even senior doctors. And it's all those little things that we think we know about managing PPE, how do you put your gloves on, how do you take them off, all those things we think we know, but really we make mistakes on and needed reinforcing. So that's really the power of using something that's been sort of universally applied everywhere. And so we're very grateful from the HSA, to the HSA, for letting us do this. And then finally, another big thing that we were involved in, or AKU faculty were involved in on a volunteer basis, was the setup of the COVID-19 Field Isolation Center in Karachi. And some of our faculty members and many of our junior residents and colleagues were instrumental in building this and developing it. And recently they even launched a very beautifully done manual on exactly how you would run the field center and so on, so that that could be replicated other places. So I'll stop with that just to give you a kind of flavor of some of the circumstances in which these partnerships came up, and a few examples of how we approach these partnerships in a multi-pronged approach that complements all the things we're doing. So I'll stop there. And again, thank you so much, Junaid.
Sure. Thank you both, Dr. Assad and Dr. Adil. We have a couple of questions, and you guys can see it. But before we go to that question, I wanted to ask each one of you to talk about how does two very different entities, a private sector, public sector, with very different cultures, governance structure, mandates, financing system, actually can work in a meaningful way. It's a question for those, not just within Pakistan, but other places who are considering this or struggling with this. What journey did you go through to get to where you are? It looks like a very effective, useful partnership between the two institutions, two entities. Maybe Adil, I'll ask you to respond first from the private sector perspective, and then obviously Dr. Assad.
I think that the key thing to understand is that when you talk to people like Dr. Assad, and even you talk to Dr. Zafar Mirza, we're academics at heart. So let's talk about the things that bind us and commonly, are together first. So when you talk about, let's think about a scientific project in a scientific way. There's a lot of automatic culture that's right there. Based on the kind of science that we're doing. And then there's a next step of differences in, well, what are the priorities? The public group has a priority of, impacting the largest number of people. The private group might have other priorities. The private group might have other priorities regarding funding. How does this thing get funded and so on? In my case, getting that a grant from an external donor was an important piece so that we could really run this, especially with very substantial financial pressures that all private medical institutions are suffering from compared to government institutions. So in short, to do this, you got to build on the things that are common to you. And then I think just be honest about, what are your priorities and how you can help. And I think having those conversations really straightforward up front were very helpful. And we also came together on a thing that we both know we could help with. Like when they brought the We Care campaign, when they said, hey, you got to do it, we loved it. I thought it was great. And we started using it for our own people as well. So that's the kind, I think, again, building on the common things helps the culture automatically proceed. Great,
thanks. Dr. Assad?
Yeah, I think Adil has kind of made a good point there that it's about building on common things and finding complementary skills or complementary strengths between the two partners, or maybe more than two partners. For example, in the government sector, the strengths are maybe access to areas where easy access to certain areas, which is, for example, data sets, for example, access to government facilities, other facilities, which may not be very much possible in private sector. Whereas the weakness with the government sector is its lack of flexibility. There are long procedures, there's inertia in movement, which is the strength with private sector. They can do things quickly, they can gather a team quickly, they can generate resources quickly, and they can roll out quickly. So the priorities are probably looking at the larger picture. The government sector realizes that what are the gaps and what should be the priorities, and then engaging the right expertise and skills through a public-private partnership. And the key, in fact, lies in the key to success lies in the initial vision of the partnership and responsibilities, ensuring that what we are expecting each other to do is doable in the real sense, and we're not generating false hopes, or we're not getting into areas where we would know the other partner would not be able to deliver. So, and then you need to have you need to approach these partnerships with open minds. It's about sharing the success, not claiming the success or whatever comes out of it individually. Yeah.
Great. Thank you. I have several questions. Some of them are public-private partnership related, others are more general. I'm going to start with maybe addressing the issue that two of the participants have asked. It's about implementation of SOPs. I think there's a lot of anxiety around, yes, we are creating all this SOPs and guidelines, but on the ground implementation is an issue, and there's concern that's leading to increase in the power of pandemic. So Dr. Assad, I think this was addressed to you. Maybe Adil can also chime in after you. What are we doing to look at the implementation of these guidelines at the front lines?
Right, that's $1 million question, and let me go explain a little bit of background. I believe most of our audience would be from Pakistan, and they do understand that health in Pakistan is a very complex subject with so many tiers of national, then provincial, then district, and then there are many ministries, and then there's private sector, and so many stakeholders. So even in normal times without the pandemic, it's difficult to steer through that how effective coordination is managed. However, what we undertook was that to develop guidelines and then leave those guidelines with certain flexibility for the provinces, for the districts, and other stakeholders to adopt and develop their own SOPs as per their requirement. Same guideline could be slightly differently implemented in, let's say, Lahore, vis-a-vis in Quetta or someplace in Balochistan. Second part of this is that these guidelines are for not only for public, but they are for departments, they are for businesses, and they are for other stakeholders as well. These are broad sections. The least part which is being implemented, or as we are concerned about it, is the general public. For them, we need to change their behaviors and maybe advertise and advocate for them to adopt. In the government departments, these guidelines are given to the departments, and they ensure that through a mechanism they implement it. For the businesses, there is a mechanism with the districts and the provincial administrations, and they actually, for example, they impose fines on if somebody is not wearing a mask and goes to a mall. And so the mall administration has to pay certain fine, or there are some other penalties which are there. So there are different ways of ensuring that these are implemented. And by the way, when we talk of NPIs, and most of these guidelines are around NPIs, we do understand that those 100% of them are not going to be implemented. So when we are calculating their impact, we do have an idea. I'm talking about the modelers and epidemiologists and public health persons, that in this situation, this percentage would be implemented, others won't. But it's a continuous process, which is, I would say, getting better. We are also learning, and we keep on tweaking our guidelines as well, depending upon the response which we get. But it's not an ideal situation out there. Yeah, I can assure you that.
Adil, you want to say something on this?
No, I think we can move on. I mean, I think what Dr. Assad Hafeez has said makes a lot of sense.
Yeah. Thank you, guys. There's other question around national data modeling. Dr. Fawzia Rabbani from EKU is asking, but generally about what is your process of modeling, where you're getting the data from, and how useful it is in terms of the priority setting and policy making?
You're asking me?
Yeah.
Okay.
No,
Yeah, there are three. We do all know that the routine surveillance system is, not something which we're proud of in this country. There are patches of excellence, but generally, it's not the best what we could have done. So in February and March, a dedicated data collection system was started for COVID, and in fact, we used the polio assets for this data collection all around the country. Now what is happening is that there are two separate systems which eventually collate at the central level. There is this provincial data gathering, which is IDMS, which is a live data system from the facilities. It starts from the districts, goes to the provinces, and then it comes to the center. It has about I think 30 plus variables around the disease. There's another more detailed and rather direct data collection system, which is again being carried out by NEOC, that's National Emergency Operations Center, which primarily deals with polio. And then this data is collated at this level. And I was just reading through the question. There are line listings, and there are, aspects like gender, age, comorbidities, the days spent on a ventilator, when the test was positive, when it was recovered. So we get this data not in raw form as modelers, but as a Excel sheet from the data repository. We use SEIR modeling system or the concept for these projections. We then have two other partners. They are in private sector. They use more of mathematical modeling. So based on this data set, three different types and three different groups independently develop their projections. And then every week we meet to collate them and develop a range for the next 15 days, 1 month, and more than that. At present, we are retrospectively thinking, we see that we are pretty accurate as far as 15 days and 30 days are concerned. But beyond that, it's a bit of a challenge. And we do realize, and let me share this as well, that our data is not perfect. There's so many gaps in it, and we have to live with this, whatever is available with us. So that's how we proceed. Then I read some question about international collaboration as well. So we have a collaboration with two institutions at the moment. One is IHME. We do have their specific inputs where we feel that we don't have that expertise. IHME actually works with us, and the other is London School of Hygiene and Tropical Medicine. So these are the other two groups. Of course, we do understand that the modelers are in demand these days, and it's very difficult to get some international person giving their time. So that's, and then every week we present as consolidated projection to the NCOC, based on which, and this has to be recognized that projections are one of the component for decision making at the ministerial level. So this is also considered. There are other projections from economic side, from human resource. There are about 8 ministries involved in this. Those are debated in the light of these projections. And then the next forum is the ECC, which is chaired by the Prime Minister himself, and all the chief ministers along with the others are part of it. So these data, these projections are then discussed over there, in addition to other considerations. I'll stop here.
Thank you. I'm going to take a question from Professor Shaila Zedi. Shana, you're on.
Right. Thanks a lot, Junaid. I'm actually thrilled to be on this webinar. And the reason is that I'm currently doing a public-private partnership review on Pakistan as to what have been the collaborations and then contrasting it with the global scenario from South Korea to European countries as to what sort of partnerships have happened there. And this is funded by the World Bank Washington. So it's a great timing. I had one question for Professor Assad Hafeez, and that is on coordination and coherence by the government across a range of private sector actors. Because as part of this review, we've been reaching out to a number of private providers. There are a number of innovations coming out, which COVID-19 has unlocked, a number of claimants to trainings, SOPs, models, digital innovations. How does the government actually manage to provide leadership and coordinate across so many private providers? And there are different sets of governments from the federal level to the provincial. So are you getting too much too soon, or do you think you're on top of it and can pick what you want across a range of private providers? So over. Thank you.
Right. You're talking about the technologies coming up from the private sector, the technical solutions. Am I right in understanding this?
So Dr. Assad, more than the technologies also in some provinces, provincial models have been developed. Other private providers have developed training. So there's quite a lot coming across. It's a great moment for collaborations, but how do you manage to really pick and choose and put everything together? The right provider, the right set of skills as the government.
Right. Let me try to explain the coordination system in the government regarding COVID at the moment. And maybe that would then allow us to understand what is happening. So there is this top decision-making body, which is headed by the Prime Minister, called ECC. And all the 6 chief ministers, when I say 6, it's provinces plus AJK and Gilgit-Baltistan, along with the armed forces and the line ministries, particularly so health, science and technology, and a few others which are like food security, climate change. They all are part of that apex body, which meet generally once in a week. Their operational arm is the NCOC, which is called National Coordination and Operation Center for COVID, in which the lead ministries are health, and then at operational level there are the provinces, which are represented by their chief secretaries, which is the administrative head of the province. And then there are law enforcing agencies which are sometimes required in the field. This is headed by one of the federal ministers, the planning minister, and this is the epicenter of all the coordination. Similar structures, the federal NCOC is kind of replicated at provincial level as well. So every day, whatever is discussed is reflected in the provincial discussions, and then a feedback comes up to the federal level. Now, this kind of relationship is also there, though to a certain different extent, because it becomes more and more operational as you go lower down, is between the provinces and the districts, where district government plays a significant role. Now, in all this, at the federal level, as well as at the provincial level, private partners or private enterprises they participate in these discussions, and they bring up whatever is relevant. For example, there is this Digital Pakistan, which is headed by one of the special assistants to Prime Minister. They have developed many um, apps which are now available. I think yesterday NITB did put out an ad for the bed registries and for how to track which beds, which wherever in which hospital the beds are available. This idea was actually brought up from one of the some um, private entities who then linked with the NITB brought it up at this level. So there are multiple levels of engagement with private sector, uh, both at the provincial level as well as the government level. As far as trainings are concerned, you mentioned specifically, there is so much need of trainings. We cannot train, let's say, 500 intensive care specialists in 1 month. So there are multiple organizations, including Aga Khan, and there are, I understand there are Pakistani diasporas working in Pakistan, public sector universities, private organizations. They're all doing their own areas of training. What we try to do at the federal and provincial level is to identify areas of need, and then develop some broad guidelines that these ought to be followed. It is practically very difficult to train. We have about more than half a million health workers in the government sector. There would be more in private sector to train all of them in COVID single-handedly from one source or one kind of training in a short time. So yeah, that's the overall mechanism of coordination, which does give linkages to private sector and to others as well.
Thank you, Dr. Assad. Adil, how do you decide? There's a huge need, and I'm sure there's a lot of pressure on institutions to do various things. How do you decide where to focus on? And how do you channelize and engage your faculty members who are already pretty thin on the ground to contribute to these national causes, being a private provider, and there are pressures on them in terms of multiple things they're doing. So, and the final thing is, and maybe I can come to both of you, is at the end of the day, once this is all over, how would you define success? How would you know whether you've been successful or with all this effort? So number of questions, and then I'll come to Assad after that.
Sure, thank you. Everything that we do needs to be kind of rooted in the mission of the university. And for the medical college and the university in general, the mission has been, it's very stated clear. It is to help support, these kinds of efforts. And so anything we can do with the government where we actually create impact at scale becomes something that should be in play. And that concept of having an impact, especially at scale, that's the whole reason to do it with the public partnership, is something that we keep in mind as we look for things to support. So how does it work? An individual faculty member, it could be from a grassroots thing, an individual faculty member says, look, I happen to have gotten the Tamgha Imtiyaz because I did all this work in a field hospital before, and now the government has asked me to come do work on this field hospital. I want to take these 7 people. Could you release me from what I'm doing and let me go do it? And that seems like something that's going to have pretty substantial impact. And then you kind of work with the person, you look at their kind of track record or what they're able to do, and how you're going to fill in what they were doing here at the university or at the medical college, and then you encourage them to go. In certain instances, you get an idea and you're not sure if it's going to work, and so then you have a conversation about, and especially conversation with other colleagues as well, to see what will actually be of significant benefit. So that's for things that come like from the grassroots level, from the faculty themselves bringing it. If we get a request from the government, then it's a whole different ballgame. If the government says, look, we need something from you, could you help us? Then of course we're gonna, we're a institution that takes great pride in, being there for the country at this point in time and at this time of need. And so then we bring all of our resources to bear. So for example, this National Tele ICU initiative, you know, that tweet from the federal minister, so we decided to do it before we ever got funding or anything of that nature. Similarly, as far as testing goes, developing the COVID tests, for example, getting the PCR thing to work in Pakistan, you know, as soon as we were contacted, we, of course, were supported. So to answer briefly how you pick, basically it's picked based on impact of where we think that as a private small institution, remember, we're relatively small compared to others, where can we have a significant impact, and how can we empower our faculty to feel good about doing something important for the nation, right? That's another important thing. You know, we want faculty to feel like by working at AKU, working through AKU, they're empowered to work with colleagues in the government to really have an impact and give back with the skill that they have. And then finally, to align our efforts, right? So we know we're good at doing lab work, right? We have a giant lab system. We know we can set the standard and how you would do it. And so that's why when we did the first several thousand lab tests, and then other people started doing more volume. And then we actually recalibrated and created a giant screening program and screening zone where we're now doing, 700-800 tests a day in a very best possible circumstance. So we decided we're going to do it, but we'll set the standard in doing so. So again, just to briefly answer, it's all about where you can create impact and where we have the capacity to really do things that the government needs in response to a request from the government.
Of your partnership with government. Adil, first you and then Assad.
Evaluate success, is that what you said?
Yeah.
So that's why I showed those 3 slides in the early on, those 3 areas that we're focused on. So first is, what are the specific areas that we are focused on? And I gave you that for that specific project. So as you develop the areas, and that's what I think Dr. Assad Hafeez was saying early on, that it's very important to have a conversation on what success would look like before you embark on the project. So for the We Care program, success looks like not only what the number is that we've trained based on the master training, but then actually doing a follow-up survey of the people who we have trained jointly, and then seeing, did they take care of patients, what the impact of this was, is there, for example, infectivity rate lower? So having true clinical things embedded in the work that we're doing together, and have a sort of M&E evaluation scheme embedded into our first steps. I think that's how you ensure that you have success. And then you look at those outcome parameters of success as you move on. So you do an interim analysis and say, okay, well, how's it going? Are we achieving the benchmarks? But having a very, very straightforward before your start, I think, with objective numbers, I think is crucial. Otherwise, you won't know if you really even had impact or not.
Right. Thank you. Assad, do you want to add anything to that?
You're asking about how do we evaluate the success?
Yeah, define success and then, yeah.
Yeah. So there are 2 aspects to it. One is, of course, the success of the project which we undertook together. So I think Adil has explained it very nicely, that we maybe add a few numbers or quantitatively and qualitatively assess that. Let me go beyond that. A successful project or a successful partnership would mean that after we end one project, both of us are willing to do another project with the same spirit. So that would be, to my mind, an important milestone for any partnership. So I'm sure we're going to achieve that with Adil there and with so many enthusiastic partners on his side. If we go beyond that, if we are working for COVID, containing the numbers of cases, containing the number of deaths to minimum possible, would be the larger goal which we would like to achieve by many such smaller partnerships. And then once this is over, and we should also be seeing beyond that, we would like these efforts and these system improvements, which we have, with mutual effort, managed to achieve in these 5-6 months. We would like these to continue in our health systems as well beyond COVID. So that would be continuation of success made from a larger perspective. Yeah.
Yeah, there's one question which is about access of the effort. Somebody asked me about rural coastal communities in Sindh. Somebody asked about Lahore. How do you extend or expand the impact of this partnership that both of you are talking about to beyond certain centers to larger Pakistan? I guess that's the whole objective of this partnership. But are there any strategies that you have in mind to further enhance the impact of your partnership? Adil, you want to go first? Yeah, sorry, go ahead, Assad, first.
Yeah, no, that's fine. Adil.
Yeah, please go ahead, Assad.
Yeah, I mean, in last 1 hour, I realized that you answer questions better than me. So,
You're just saying.
But anyway, that's something which we would be thinking of. We partnered in WeCare with AKU because of its physical presence in Sindh and its close working network with the local partners. We are partnering with UNICEF at this point in time to address the rural component of awareness by using the infrastructure of lady health workers who are, primarily in the rural sector. So there is a plan working with them. And similarly, I think in coastal areas, maybe AKU is in a better position to have more presence there. Adil,
I think as far as access goes, we, one thing, for example, we did with all of our courses, even before we started the WeCare work, was to make an active decision to put our courses on for free. And, one good thing leads to another. I think that one of the reasons why we were able to attract some external funding is because people said, well, look, these guys are trying to do it for free. So that was the one thing about access. The other, I think, important point here is that we have to continue partnering with other colleagues. So for example, the other private organizations in Pakistan, smaller places, for example, if you're talking about, I see one question about the rural coastal communities, that's the kind of group there, like, for example, NGOs that work specifically in the rural area. Those are the kind of things where we can use what we've learned and help partner with them and then move forward. Similarly, we've done one with the colleagues in mental health. So we understand mental health is a huge problem. And there are 2 or 3 organizations like Sehat Kahani, like Indus Research or Interactive Research and Development, and a few others. They were trying to figure out a way to partner to do more mental health awareness and psychological counseling. One of our young students actually worked with them and they got a grant. And so we became kind of the group to bring these other groups together and help create a partnership or sort of a network for mental health across these groups. So there is certainly a way to increase access. It's just that has to be part of the objective. I think early on the part of the objective is, one of the outcome is how accessible you are, then you'll be able to create access. It can't be an afterthought. It has to be built into the design of the project.
I have one last question before we sign off, and that's about, the lessons learned so far. If you were to change a couple of things from your perspective about public-private partnership from experience in Pakistan, what would those things be? And I guess, Dr. Assad, I'll start with you. How can we make it more effective, more useful for country and for individuals who are involved?
There could be many things, though we're living in different times now. COVID times are slightly different than I hope what would happen in post-COVID times, in times to come. But I would go back to my initial comments that there should be, if there's a larger, larger group of private sector organizations, academia, which are willing to be part of such partnerships, and they are spread geographically at their advantage. I, as a as a government institution, would be more comfortable working with more than one organization. We have an issue in Pakistan that not many private sector academic institutions, I'm not talking about NGOs and civil society organizations, not many private sector academic institutions are willing to work with the government. And I don't blame them. There are issues on both sides. So if there's is the clear understanding at the beginning, the terms of engagement are well defined and are legally robust, I think it would be easier to work with private sector and vice versa.
Adil?
Yeah, I'd like to build upon what Dr. Hafeez just said. We're grateful that we, both of our offices worked together to create sort of a legal framework. Part of this was because patient care was involved. And we have, obviously, everybody has lawyers and malpractice insurers and so on. So we had to create a legal framework to actually move forward. But that is very helpful because you kind of have an idea of what you want to work on. And even when we were doing that, we had a few good conversations about, hey, I want you to focus on this and we'll focus on that. So that really helped actually distribute the work. So the key here is to, again, figure out what each other is able to do and complement. And that creating that structure certainly helped us. And I can see why some academic institutions are weary. I mean, there are all sorts of issues that do come up. On the one hand, we're partnering together to do these things. On another hand, there are all these questions that have to do with how our academic programs are going to work and so on. And a large place like AKU that has different levels of people who work on all these things, it's probably easy to do, but I can see the difficulty if you didn't have such a developed structure. But I will say that in this day and age, people really are trying to make a difference. And I must acknowledge the government has done above and beyond what anybody could ever expect. I mean, look at the resources and the amount of GDP and federal rupees that are allocated to health. Compared to that, what they're able to produce is, in my view, pretty remarkable. Right? It's very remarkable if you think about the actual impact on the amount of resources that they have. So, in my view, the private folks should look and say, look, the government folks are really upping their game and doing more than what could ever have been expected. And we need to rise to the challenge and meet them where they are to make a difference, inshallah.
Great. Well, thank you so much. This was a very, very interesting, useful conversation. I'd like to, again, thank you both, Dr. Hafeez, Dr. Adil, Haider, for taking our time. I know how busy you guys are. And also thank you to all the participants. Next week, we are going to be talking about the critical care of pediatric patients with COVID. So we'll change our Qibla from very policy level discussion to more clinical. So same time, please join us. And again, thank you all for being part of this.
Thank you, Junaid. Thank you, everyone.
So much. Thank you, and thank you for being here. Thank you, everybody. Good night.